directives and to follow the directives clients provide. Living wills are documents instructing healthcare providers to withhold or withdraw life-sustaining procedures when death is imminent. Living wills may also list procedures the person wants done when death is imminent. Each state has its own requirements for living wills. Generally, 2 witnesses, not necessarily relatives or healthcare providers, are needed when the client signs the document. Healthcare surrogate statutes are also referred to as a durable power of attorney for healthcare. Clients prepare these documents to appoint someone to make healthcare decisions if and when they are no longer able to make decisions on their own behalf. The major difference between the 2 documents is that healthcare surrogates make decisions in many situations other than when death is imminent. It's important to discuss advance directives with your client as soon as possible. As you're filling out the admission form, you might ask your client, "Did someone in the admitting department ask you about advance directives?" If your client seems vague about it, explain, "It is a document that tells us what to do if you are unable to speak for yourself." There are 2 types. A living will goes into effect if you have a terminal illness. The durable power of attorney for healthcare is someone you choose to make decisions anytime you cannot speak for yourself. Then the client might remember someone mentioning it earlier. Be sure to give the client plenty of information, such as, "Since these are legal documents, we have a specially designated staff person who can explain all the legal issues. The document must be notarized, and this person can do that as well." If the client doesn't want to speak with anyone, be sure to document that, and if the client does wish to speak with someone, notify that person. Your hospital will have some information or a pamphlet that you can give your client to read about advance directives while waiting. Question: You have a client in the ICU with a living will stating that she doesn't want to be on a ventilator in the event of respiratory failure. The client's adult children are at the bedside, urging the physician to intubate and save their mother. What is the nurse's responsibility in this situation? The nurse is an advocate for the client and therefore must remind the physician and the client's children that her living will specifies that those are not her wishes.
Legally competent people may specify their intentions to have their bodies or organs donated for medical use after their death. Consent forms are available for this purpose. In many states, adults can sign the back of their driver's license, indicating their intention to donate. In fact, signing the back of the driver's license is all that is required in some states. In other states, the family still has to give consent for organ donation after the person's death, or can revoke the deceased person's indicated consent. State laws define whether or not a nurse may serve as a witness when an individual wishes to give consent for the donation of organs or the body. The nurse must be aware of the policies and procedures of the institution and the laws of the state where they practice, if they are asked to serve as a witness. In most states, required request laws stipulate that, at the time of a person's death, a designated healthcare provider, called a trained requester, must ask family members to consider organ or tissue donation. Required request laws came about because of the shortage of suitable organs for transplantation. The Uniform Anatomical Gift Act addresses many problems of organ donation. For example, the physician who certifies death cannot be involved in the removal or transplantation of organs. The National Organ Transplant Act of 1984 prohibits the purchase or sale of organs. However, many myths still exist and some families are confused about organ donation. A common one is that the donor's family must assume some medical or surgical costs related to donation, when in fact, it is the recipient and/or the recipient's health insurance carrier that assumes responsibility for the financial aspects of donation. During the decision-making process, the nurse should assess the family's knowledge, support them during this difficult time, and provide resources. Remember, only specially trained or designated staff may legally request organ donation. The nurse should follow the healthcare agency's policy on when and whom to notify about the brain death or expiration. So what do you do if you have a client whose death is imminent? First, look in the chart to see if anything about organ donation has been documented. If you haven't been trained to request organ donation, then review your facility's policy manual to find out whom to contact and how to proceed, or just ask your supervisor to guide you through the appropriate steps.
After assessment, you will use critical thinking skills to establish priorities for care. Priorities identify the sequencing of nursing interventions when a client has multiple needs. Establishing priorities is not merely a matter of numbering the nursing diagnoses on the basis of severity or physiological importance. Rather, priority selection is the method the nurse and client use to rank the diagnoses collaboratively in order of importance based on the client's desires, needs, and safety. Maslow's hierarchy of needs can be used to designate priorities. The hierarchy of human needs is arranged on 5 levels of priority. The first level is physiological needs: breathing, circulation, food, and water. The second level includes safety and physiological and psychological security. The third level addresses love and belonging needs, including friendship, social relationships, and sexual love. The fourth level includes self-esteem needs, such as self-confidence, achievement, and self-worth. The fifth level is the need for self-actualization, which is the state of achieving full potential and having the ability to solve problems and cope realistically with life's situations. The basic needs at the first level are, of course, the highest priority. This hierarchy of needs is a useful way for nurses to prioritize the needs of a client. A nurse prioritizes all the time, especially when assessing which client to treat first. For example, in post-anesthesia recovery, which post-surgical client would you assess first? A client who just had a laparoscopic appendectomy, a thyroidectomy, a total hip replacement, or a vaginal hysterectomy? You would be concerned with the airway of the client who had just had a thyroidectomy and would prioritize using the ABCs. Nursing diagnoses that, without prompt intervention, could result in harm to the client have highest priority. Diagnoses related to gas exchange and cardiac output, for example, have a higher priority than diagnoses related to self-concept. Priorities can be high in both the physiological and the psychological dimensions. The nurse should avoid classifying only physiological diagnoses as high priority. So which client should you assess first? A client with no urine output for 5 hours? An unrestrained client with hepatic encephalopathy? A client newly diagnosed with cancer? Or a client injured in the same motor vehicle accident that resulted in the death of his spouse? Prioritizing by using Maslow's hierarchy, the answer is safety first. The client with hepatic encephalopathy could become confused and he is unrestrained. Sometimes safety is even more important than a physiological need, such as elimination. And the other options fall a bit higher on Maslow's hierarchy. Whenever possible, the client should be involved in setting priorities for his own care. In some situations, the nurse and the client assign different priority rankings to the various nursing diagnoses. These differences can be resolved through open communication. However, when the client's physiological and emotional needs are at stake, the nurse must assume primary responsibility for setting priorities. When the nurse uses clinical judgment and diagnostic reasoning to assign priorities to diagnoses, the needs of the client, the resources of the healthcare system, and time limitations are all considered. So, if a client from the emergency department will be admitted to your unit after reduction of an open fracture, which client would be an appropriate roommate for her? A client who has COPD exacerbation and pneumonia. B, an immobile client who has a Foley catheter in place and a urinary tract infection. C, a client who